All right, today we're going to talk about herpes zoster, immunocompetent host. So there is another presentation that I'm not going to do, but that for people that are not immunocompetent. So this is just for your immunocompetent patients, main ones you guys will probably be dealing with. But if they are immunocompromised, just know that this stuff does not hold true. But for my course, testing purposes and stuff, we'll just stick to immunocompetent, and we'll just stick to the drugs here. Spoiler alert, it's a herpes zoster. It's a viral infection. So we're going to be talking about antiviral medications. So focus on those. A couple other medications here, some analgesics and stuff, but not too much. Again, not too bad, but enough to like you still have to look at it and study it probably a couple times, but not a ton of drugs. Just some background for everybody. Make sure everyone is on the same page. But the VZV, varicella zoster virus, I just like saying VZV. Primary infections known as chickenpox. So you guys probably, unfortunately, had that. Maybe growing up, I don't know, maybe not, and are familiar with that. The second, if you are reinfected, herpes zoster is also known as shingles. So chickenpox, shingles, that's usually what your patients are going to refer to them as. But anyways, here's just some definition here. Shingles is usually in older adults over 60, but it can happen in anybody's age. I don't know if, depending on all y'all's family and friends and stuff, it seems like everybody knows a younger person. One of my brothers, for example, he got it when in his 20s. So it can, unfortunately just kind of happen to anybody, but typically it is a geriatric issue or concern. But you guys might see this just in a number of different settings, depending on where you're working in the future. Go ahead and read through this. One thing that makes the shingles a little bit different is it's usually just one dermatome that's affected, but it can be more than one. It can be all over. So anyways, it just kind of depends. Management, like I said, antiviral pharmacological management, specifically antiviral therapy, and then analgesic medications to help with the pain and discomfort the patients feel with these things. Here are the goals. You guys can read through those. Just kind of FYI. That again, a lot of this stuff hopefully will maybe help with pathophys. It's just kind of full picture here for me. Focus on the drugs. So if it's less than 72 hours of onset, it's going to be different. The treatment's going to be a little bit different than if you have them with after 72 hours of onset. The patient comes to you. So depending on quickly, I would bet that the majority of patients you're going to see are going to be coming to you sooner than later. So most patients, if they get the shingles, it's painful, it's uncomfortable, you have these weird lesions on your body, they usually don't wait like 4 days to be like, I don't know, maybe I should go get this checked out. They usually come to you. So most of your patients, I would bet, are going to be less than 72 hours. But still, I mean, know both for studying purposes, and it's good to know both for your board exams, etc. But anyways, and that will be good if they come, because it maximizes the benefit of the treatment. So these antivirals actually work better and are more effective. So anyways, yeah, so again, if it's past 72 hours, it affect the treatment. You may not want to give antivirals. It also kind of depends if the patient is a poor historian. So if they're like, oh, when did this start? What you're trying to figure out was 72 hours ago, and they're like, it was anywhere from like a day ago to like a week ago, and you're like, what? Again, you're professionals, so you're not going to laugh at them and like make faces at them. You're like, okay, yeah, I see 1 day to 1 week time frame. Okay, all right. And it's just like, why is this person like, but anyways, not going to start picking on fake patients I'm just making up here. But so if the patient is a poor historian, you'll notice here it says there's likely minimal benefit of antiviral therapy. If the lesions have encrusted, so if the lesions are encrusted or not, that can give you an idea. That can be something that if you feel like the patient isn't really that great of a historian, that could be something to look at. But then it's also too, like, I have seen our filled prescription antivirals where the lesions maybe already have partially encrusted and stuff. So it's going to also kind of depend on your patient and their presentation and all their signs and symptoms, right? Choice of agents. So we're going to go, like I said, during the spoiler alert, antiviral medications. So here we have the three: acyclovir, valacyclovir, famciclovir. Of those, the acyclovir they're all equally effective and have all been shown to be good at helping treat the virus. But because of dosing, and let's see that we have it on here, acyclovir has more frequent dosing, so patients don't like it. And here we go. It's 5 times a day versus 3 times a day. So for this uncomplicated shingles, you can go with the valacyclovir or the famciclovir. Sometimes it does depend on the formulary. So if it's usually outpatient, but depending on if you're working at someplace with those formularies, some outpatient clinics have formularies, or depending on which pharmacy this patient's getting it filled at, that may kind of judge or guide which way you go. Other thing too with the acyclovir is that you do have to be concerned about the renal function. So that may be another reason to not maybe choose that first line. So usually valacyclovir, famciclovir are the ones are going to be first line, but as far as is they're efficacious or not, I mean, you can pick any of these if you see one as an answer choice, for example, as far as first line and choice of agent for the herpes zoster. Adverse effects aren't too big of an issue, just GI and then headache you have to be worried about. And these are higher doses here than what is average, but they have been well studied and kind of well documented, and they should be okay for the patient. Analgesia, like I said, you have to think about some pain medication. So usually it's most patients are okay with you just prescribing them Tylenol. So that's over the counter. Acetaminophen is the generic of that. We'll talk about these medications a lot more in musculoskeletal module, so stay tuned for that. But if you are anxious and really want to read about it, look at this little Mickey Mouse glove here. Just go ahead and click on the I don't know, I guess it's a Mickey Mouse glove. I don't know whose glove that is. Go ahead and click on those and you can read more about the drugs if you're just like dying to know more about those. And you guys, wait a minute, what am I saying? You guys are busy enough and you're like trying to, you have enough to study, but just in case, if you want to. But usually the acetaminophen, not as strong as of an analgesic medication. You can combine those, and they make some combination products. They make Tylenol with codeine, Tylenol with tramadol. So you can go with that. And if it's really severe, they can't sleep, it's really bad. And again, this is going to be patient specific. You can go with the stronger opioid analgesics, so oxycodone, morphine maybe. But typically you just stick to the Tylenol, maybe add some codeine to it, maybe tramadol. For uncomplicated, you should not prescribe gabapentin, tricyclic antidepressants, or steroids. So historically, some of those were thought to be beneficial. The gabapentin is used for nerve pain, so they thought. But anyways, as of now, evidence does not support the use of gabapentin, tricyclic antidepressants, or steroids. And this is again for uncomplicated. Later, we're going to see with more complicated versions of this viral infection, steroids are prescribed and are preferred and used. But in none of your patients should you be prescribing gabapentin and tricyclic antidepressants for the treatment of this viral infection and or the help with the symptomology. Secondary bacterial infections, they can occur, and so patients need to be mindful of that and be educated on that. So if they have any of these signs and symptoms down here in this last bullet point that show that it may be a bacterial skin infection, they need to be appropriately treated. So they need to be thinking about the staph and strep, the staphylococcal or streptococcal antibiotic coverage, maybe a topical antibiotic for that. So that's just something to think about. And what happens is just because there's a lesion and stuff, people scratch or whatever, it gets dirty or whatever, and unfortunately that can sometimes happen, but not super common. It is rare, but again, part of your patient education. Patient monitoring. You guys can just read through this. This is just more FY for my course. Recurrent, same thing. Just go ahead and read through it. It's not big as far as test questions are for me, but just go ahead and read through that. Just also note too that there's no data regarding the potential benefit of the zoster vaccine in this scenario. Complicated. So this unfortunately happens sometimes. There are some complications even with immunocompetent patients. So basically here you want to go to, before too, those antiviral medications were PO. Well, these you'll probably want to go with antivirals that are IV and or longer therapy. And then this is an instance where if you have the complicated infections that you will want to go with your steroids. So note that. So uncomplicated, no steroids. Complicated, so uncomplicated, PO, antiviral, no steroids. Maybe some Tylenol or some pain medications depending. Complicated, you're going to go with IV, antivirals, and steroids. And the specifics are laid out here. So if it happens in the eye, the ophthalmicus, as unfortunately it can be very serious and have some very bad problems here. And it's very critical that you catch it and you treat it, because it unfortunately can cause a person to go blind. It's also an instance too where ophthalmologists or specialists will probably be involved with this treatment. But you'll notice the same antiviral medication, so that's nice. You guys don't have to worry about too many different drugs here, but that, and then also topical steroids can help. And then so here's an example of, you can use IV acyclovir there, and this will be inpatient. You know, it is more complicated, and so this is something where the patient needs more supervision. Acute retinal necrosis too, again, more severe, so you start with IV acyclovir, and then you can go to PO, so up to 14 days, and then you can go to PO valacyclovir, 1 gram 3 times a day for an additional 6 weeks. So again, complicated, a lot longer therapies. I mentioned the glucosteroids again. Those are important to help because they are anti-inflammatory. So here's an example of using prednisolone. But yeah, so anyways. The Ramsay-Hunt syndrome, this is where there's ear complications, unfortunately, and here's what can be involved, the specific triad here. Same antivirals, you notice here. So for most patients, they recommend valacyclovir, 1 gram 3 times a day, and then the prednisone in addition. With neurological complications, again, IV antivirals. You guys are probably getting hopefully getting a theme here. IV antivirals for complicated. So that will be important for testing purposes. Complicated versus uncomplicated. You know, IV versus PO. Steroids versus no steroids, right? So make sure you keep those straight when studying. The pH end, just FYI for me, don't worry about looking more into it. I mean, it may come up in ICM or in pathophysiology, but for my testing purposes, don't worry about it. From any transition to others, this is important, and because it can be transmitted. So just read through this, but it's just more FYI for testing purposes for me. You know, hand washing, staying away from people, especially staying away from pregnant women or premature low birth weight infants or immunocompromised individuals. So those are things to stay away from. So that is it for me. Like I said, just, you know, complicated versus uncomplicated, make sure you know the difference there. But it's basically antivirals, analgesic, coverage. Oh, and by the way, too, for complicated too, weren't explicitly saying it, but when the person's hospitalized and they have the complicated herpes zoster, I mean, definitely analgesic approach too. You want to make sure you're mitigating and treating pain appropriately as well. But anyways, if anything you had questions about, feel free to email me as always. And thank you guys for your time and attention. I'll talk to you later.